Two, one. Good afternoon. This is Dr. John Bennett broadcasting from Miami. Today we have the pleasure of having Slaven Golčević, a medical student from Croatia, that's going to do a presentation on telovelar approach to the fourth ventricle from the Rhoton chapter of the cerebellum and brainstem. We're also joined by Dennis Nerdayan, MD. He's a medical student from Greece, now studying in Germany. Let's first say hi to Dennis. Hey, Dennis.
Hello, Dr. Bennett. Hello, Slaven. I'm really glad to be here again on this beautiful platform to see these lectures. And starting resident neuroanatomy is always in the first place.
Yeah, first year neurosurgical resident, fresh.
Yeah.
Okay, Slaven, could you just say a little bit about yourself and then go on to your presentation, please?
Yes, hello everyone. My name is Slaven Gojković. I'm a medical student at the University of Zagreb in Croatia, and I started this course a year ago, as I will say more about. And I started the presentation because I was so fascinated with Professor Rhoton's work and with the materials the WANS provided online. So I'm very glad also to be here on this platform again and to make another one in the series of these presentations. This project is basically, it was started at the University of Zagreb at the Croatian Institute for Brain Research as part of the Student Society for Neurosurgery that we have here in Zagreb. And I never hoped that it will get such a wide interest. I can say an international interest. We have here Dennis, we have here Dr. Bennett. And it's a small society which started out as around 20 students and now has grown to around 200 members all around the world. So I'm very glad that this is happening, and I hope that I will keep up the work. So today I would like to take you through the one of the more modern neurosurgical approaches, and this is the approach to the fourth ventricle. So I designed this course more to be an overview of some basic skull-based approaches, heavily, reference to the most popular textbook in neurosurgery, and that is the Rhoton Cranial Anatomy and Surgical Approaches textbook. That is I believe that it still is the best-selling work in neurosurgery. And when we will go from the posterior fossa, which is at the back, to the anterior fossa, and try to view all the most basic approaches in the most basic way. So I hope every medical student and especially every resident will be able to understand this. Okay, so I will just go to my presentation to start with it. Okay. So can you see the screen?
Hold on, Slaven. Let me check here. Yes, yeah, excellent.
Okay, great. And now this you can see the first slide.
Yes.
Yeah.
Okay, great. Okay, so what you see here is actually now history. It's the first poster that we made for my presentations at my medical school in Zagreb. Almost exactly 1 year ago. It was 1 year and 1 month ago from now. So you can see everything here. Then it was just a project that was developed to be a local project for my school. But as time go on, I met Dr. Catherine Cole from New York, who featured me in her show of Art on Call, which is based on neurosurgical TV. And then I met Dr. Bennett, and we made it really an internationally attendable course, which bound many students together, and I found many friends through this endeavor. So let me start now with the presentation. As I said, today we will focus on the telovelar approach to the fourth ventricle. But first, let me say a few words about Professor Rhoton and how I got the idea. I just wanted to say that Professor Rhoton is a professor of neuroanatomy at the University of Gainesville in Florida, and he is one of the most well-known world's author in the field of microsurgical anatomy. Actually, exactly 1 year ago, when I started these courses, Professor Rhoton was still alive. He was in his late years, and it just so happened that I got the chance to email him and tell him that I would like to make these courses in his name to honor his work. And he answered me with an email saying that he was touched with my effort, and that he wished us best of luck in this thing to be done. So I'm really glad that I got my chance to contact him before he died. And actually, 3 months after we started this, he was he died. So it's really an amazing thing what happens over the course of a year. So this year we are starting these courses for the second time, and unfortunately Professor Rhoton is no longer with us, but I hope that his work lives through these small steps provided by medical students and residents throughout the world. So let me just jump to the topic now. This is actually a remake of the chapter in the textbook Rhoton's Cranial Anatomy and Surgical Approaches. So this chapter is about the cerebellum and brainstem, and it briefly talks about the Thiele-Wheeler approach to the fourth ventricle. But just to make it more interesting, we will make the Thiele-Wheeler approach our first subject today. Okay, so this image is probably well known to most of medical people around the world. This is the skull base in a cadaver. And if we try to look this clockwise from the, I don't know if you can see my arrow here. Can you see my arrow?
Yes. Yes.
Okay, great. So if we try to view this skull base as a clock, I mean, in this fashion, and if you go from anterior to posterior, oh wait, this shouldn't happen. Okay, so if you go from anterior to posterior, we can see how these approaches lead us to certain parts of the skull base. So as we all know, it is consisting of the anterior cranial fossa, the middle cranial fossa, and posterior cranial fossa. Of the three fossae, the posterior cranial fossa is the most complex one, and it contains 10 of 12 cranial nerves, and this is why it's so complex in its nature, and it basically contains all of the infratentorial space. The tentorial cerebelli is a membrane that divides the supratentorial, which is above the tentorium, and infratentorial space, and this is the origin of this tentorium. So the upper margin of the petrosal parts of the temporal bone. Okay. Okay. So if we view these approaches, we have the transclival approach, which leads us directly to the clivus. This is an interesting approach. We will do more in the last stages of our hangouts here as part of the Rhoton course, when we will discuss the anterior approaches. But what's interesting about it is that it can be done, and mostly is done today, through the endonasal endoscopic approaches, through the sphenoid sinus, and it's kind of, it takes us to the sella turcica, or the seat of the hypophysis, or the pineal gland. This approach can also be done through mouth, but that's not really the case today. It's not really done through the mouth anymore. Then we have the anterior petrosal or middle fossa approaches. This approach is very interesting because the true anterior petrosal approach was designed by Professor Takeshi Kawase, and it is an approach that is well known for preserving the hearing. So you don't need to go through the cochlear part of the temporal bone, which contains the important hearing structures. You go anteriorly, and it provides you with the access to the CP angles, cerebellopontine angle, which is really useful to preserve hearing in some patients. And you have posterior petrosal approaches, transtemporal, retrosigmoid, then far lateral, which will be the topic of our next meeting, and finally the midline approaches, which are the approaches to the fourth ventricle. And one of these approaches is the Tila-Wheeler approach we will discuss today. Okay, so let me now go back to what I promised, and this is the baby steps approach, and I'll try to play this video. So please tell me if you can see this video here. Okay, no, so I'll have to open it manually.
It's a video?
Okay. Yeah, it's a video, but it seems that I'll have to open
we'll
it.
see. We'll see. But
yeah, I have it all here in.
Can't see it yet. No, we can't see it. No.
Yeah, I know. I'm opening it.
Oh, okay.
I just need to get the. Well, maybe it's all basically on YouTube, so I'll try it this way. Just a second. I'm very sorry for the delay. I didn't know that it won't work like that. So do you see my YouTube here? Okay, so do you see this?
Yeah, see YouTube.
Yeah.
Okay, so hope I will get the video now. No, it's not actually what I hoped for, but okay, let me go to the AANS page, which is the page which provides these videos. It's actually the homepage on YouTube of the American Association of Neurosurgical of Neurosurgeons. So it has here all the Rhoton collection, which are great videos to watch.
The whole collection?
Yeah, the whole collection. It's consisted of 14 videos. Now it's 21 because Professor Rhoton's fellows did more videos through the course of time. And now you can basically watch all of these approaches discussed by Professor Rhoton. So it's really nice, but it's kind of more for residents. So I really do my best to be more familiar to medical students, and not just residents, because I'll try to make it simple. Okay. Let me mute this. So this is the video I was searching for. If you can see the video going on, it's basically a video that is showing how do you position the patient. This is one of the possible positions for doing the posterior fossa approaches, midline posterior fossa approaches. So basically, if you consider how will you enter the posterior part of the intracranial space, it's very logical that you have to go through the skin first, then through the soft tissues beneath the skin, then through the bone, open the dura, and then you will arrive to the brain structures inside. Okay, so to do this, you need to position your patient correctly. One of the most popular approaches to do this in the past was the sitting position we can see here. And now it's a very controversial procedure, which because it is very connected to the risk of air embolism, which can occur in some patients. Because, as you know, the pressure is negative above the level of the heart. And if you position the patient like this, sitting on the surgical table, these pressures go negative, and then you can have the sucking in of the air into the superior sagittal sinus. Okay, but let us consider this approach now. So, positioned in a sitting fashion on the table, it looks kind of funny. It looks like a giant, how can I say, like a giant hill on the table, because the patient is completely covered with green surgical sheets then. And you can see here the Mayfield scalp clamp, which is holding the head of the patient in place. The hair on this posterior part is shaved, and the incision line is marked. It is a midline incision, which you can see right here. Okay. And then, as we go on, this surgical area is prepped with iodine, and it is then prepared with craniotomy drapes prior to the incision. Okay. So we can see here the application of iodine. I said this approach is very controversial because, for example, in Romania, Stefan Florian has a great experience of this approach, and they're doing basically all the approaches to the posterior fossa via sitting position. In Japan, for example, in Tokyo, this approach is forbidden of the patient because of the risk of the air embolism. So it's really one of the most controversial topics in neurosurgery today. But I still wanted to show this to you. So after we've done the midline incision, dissection of the subcutaneous tissue is performed, and then the skull is approached. Okay. So all the time, careful hemostasis needs to be obtained. So for the use of this, the bipolar forceps is used, and this is a device that coagulates the vessels, and it has the plus pole and minus pole as a forceps, so everything that you catch with it can be burnt or coagulated. Then after this is done, the craniotomy burr holes are put on the skull. Okay, so we can see here the application of these burr holes. Like this, in the cases of Hari, you have two options for craniotomy to be performed. So you can do either a craniotomy or craniectomy. Craniotomy is a procedure in which you remove the bone flap, but then hold it in a physiological solution. And then you can return it back to the patient's skull and fix it with titanium plates. So that is the craniotomy or osteoplastic craniotomy. In osteoclastic craniotomy, you remove completely the bone part, and this can be done with rongeurs or a special instrument that bites away pieces of the bone. So the bone is permanently damaged, and it is most of the time, you can use some plastic surgery materials to cover the defect in the bone. Okay, so now after the bone has been removed, dura is exposed beneath the bone. This dura needs to be opened, and you will see here an interesting thing. So if you can recall a bit of the anatomy of the intracranial space, which I will discuss after this video, you will see that there is a sinus that is positioned here, and that is the inferior sagittal sinus, which needs to be coagulated and divided prior to opening of the dura. So let's see how this is performed in this video. You can see here the dura, the cerebellar hemispheres, and careful opening of the dura. They chose to have the okay, so this is the opening of the dura in the fashion which has two windows opened, and then the sinus is ligated, as you can see here, and finally divided. Okay, then these parts of the dura are sutured with retraction sutures to the outer part of the surgical field, and cerebellar hemispheres are uncovered beneath. Okay, so afterwards, when you are closing the wound, you just go up the layers. So as I said, you need to first do the duroplasty, But before this, you need to provide really good intracranial hemostasis. So meticulous intracranial hemostasis is the first step in the wound. After this, you can suture back the dura, as you can see being done here. You can also apply some of the surgical glues to provide a tight, watertight suture, which is really important because of the CSF leaks. It is one of the things that neurosurgeons are most afraid of. Titanium plates are applied, so this is the osteoplastic craniotomy. And then finally, you can suture the subcutaneous tissues and go back to the upper portion of the skin, which is closed with staples in this case. Okay, so after this video, we will go back to the presentation. Just a second. Hope you can see the presentation now. So there are various positions in which you can position the patient. One of them is also the prone position with face down, and also the lateral or park bench position, which is similar to this. And most of the time, neurosurgeons are choosing one of these alternative positions to protect the patient from the air embolism, which can occur. I will just take a minute now to see what happened with my presentation. After this, we'll have no more things with the videos, so all the pictures are in the presentation. So I hope it will all work fine. Just a second. This is not working. Okay, excuse me for the technical issues. I'm waiting for this disk here.
You're looking for another video?
No, this is a disk on which I have my presentation, but it seems that it has some problems. Okay, I'll try to open it manually like this. Okay. All right. Rhoton cranial anatomy. Okay. So now, but wait, this also doesn't have images in it. Okay, I'm not satisfied with this. I'll try to fix the disk.
Okay.
For this.
The crowd is getting unruly.
Oh, really? What's going on there?
The crowd is making noises.
Hear that too. So.
They're starting to throw fruit.
Oh man! I was afraid of this, So
that's all right.
I'm really.
That's okay.
Okay. Well, you can see what I see. Yes, it's kind of I can open the presentations, but there are no images.
Right. It looks like the slides aren't coming through.
Yeah,
for some reason.
It's really interesting. Okay, let's try another presentation. I have a bunch of these.
Okay.
Here, so I'm sure one of them will work.
Okay.
Okay, so maybe this one will. All right, so it seems that this one is working. Here are all the slides here. Some of them are. Yeah, but you see, I really need these slides, and they're not here.
Yeah.
So.
Okay.
So it's interesting. Okay. Let's try to see what's the trouble with this. I mean, it's okay. Just give me a minute. Right, I'll fix it. Just a second. No, it's been some time during the summer break and stuff that we didn't do these presentations. So I guess I kind of went all in it. So, okay, this is not.
When the images are not in the same file with the presentation, Office doesn't read them or something like that.
Well, I'm interested. I'm really confused with this because these images are part of the presentation, and as you can see, I can't see them here. So I'll just close it up and try to put it again. It's basically a new USB issue. Okay, so after this, I won't go out of my presentation anymore, and it seems that it works now. Okay. Yes, it works. Okay, we're back in the game. So just tell me if you can see the presentation again.
Yeah.
Yeah.
Okay.
Okay, thanks for being patient.
We can see it now, yeah.
Yeah, great. Okay. So do the anatomical part. So it's a question now, when you have done this skin incision, soft tissue dissection, enter the skull and cut the dura, what will you see inside? This is a great question. So I have here some of the beautiful Rhoton slides which show this in detail. We will cover these slides through the course of time. But for the first part, I just want to show you some of the basic things that you can find inside the skull. Okay, so as you all know, this is the cerebellum. So what you will basically see when you do the craniotomy in this posterior part of the cranium, you will see the hemispheres of the cerebellum. Okay, so these are two large hemispheres here, and one put in the middle, which is called the vermis, the cerebellar vermis. It's all consisted of many parts. I will not go to these details now. You can find them all in the chapter on the cerebellum and brainstem in Professor Rhoton's book. So if you now consider this vermis here and these two tonsils of the cerebellum right here, you can get the general image of the anatomy that you will make here. So, you will see here. So you see the hemispheres, the vermis, and the tonsils. This is the medulla oblongata and then the spinal cord down here. This is the posterior arch of the atlas, and this is really one of the most important structures here, the atlanto-occipital junction, which holds the entire head on junctions between this vertebra and the occipital bone. So it's really a junction which is like the old antique giant who is holding the world on his shoulders. It's really the same if you consider this anatomy. And then you have here the vertebral artery coursing through the foramina vertebralia. These are the vertebral foramens here on the lateral parts of the vertebrae and courses into the intracranial space. But let's not make it too complicated to you. So now when you zoom into this vermis part and the tonsils part, you will eventually see this foramen and this thin part of tissue which is a kind of see-through membrane. So this part of the tissue is consisting of the tila choroidea in the upper part. The tila choroidea in the lower part and the velum medullare inferior in the upper part. So it's really the structure we are looking for tonight. So I don't know if you can follow me here. I hope that you are all oriented where we are now and what are we searching for. So we are searching for the ways in which we can enter the fourth ventricle, which is positioned behind the vermis here. Okay, so it's a tight space between the cerebellum, which is forming the roof of this fourth ventricle, and the brain stem, which is positioned in the front. Okay. Let me just go through some other slides to give you a much more, a better perspective of this. So now, basically, when you remove the cerebellum, you will see this. This is an anatomical cadaveric dissection. So the cerebellum sits right here, and when you remove it, you basically see this field here. So this whole area is the brainstem, you know, and this is what is called the rhomboid fossa. Okay, and fourth ventricle is the space which is between the rhomboid fossa and the cerebellum. All right. So now you have the idea where are we trying to go. But to go there, we need to pass the giant barrier, which is called the cerebellum. Okay, so in the past, what neurosurgeons did to enter this area of fourth ventricle, they cut right through the vermis. It is interesting. So when you cut right through the vermis and you divide it into half, which is called the splitting of the vermis, then you have the cerebellum open like the doors. Okay. And Walter Dandy, which was one of the fathers of modern neurosurgery, stated in 1920s thereabouts that you can cut away large portions of the cerebellum or remove them without any significant neurological deficits to occur. And this is really interesting because if you consider that we have 50% of all the neurons in the brain positioned in the cerebellum, and you can cut away almost everything of the cerebellum without significant neurological disorders to occur. It's really an interesting fact. So that's really the thing that is confusing. So in the older years of neurosurgery, every approach to the fourth ventricle was being done through the splitting of the vermis. But as neurosurgery developed and as the techniques of surgery became more minimally invasive and more refined, new approaches needed to be developed. And Professor Rhoton jumped in here with his passion of trying to invent new neurosurgical approaches to the very hard approachable parts of the cerebellum. So anatomy always played the central role in this. And what he found is that if you just try to go through these membranes right here, which are, most of them are significantly avascular, so you can find some significant vessels here. So if you just put the cerebral spatula here and retract this part of the cerebellum and expose these membranes here, you can cut right through them and it leads you to the fourth ventricle essentially. So it doesn't probably look like a big deal, but it's interesting that it was needed almost, I don't know, 50 years of neurosurgical development to get to this point. So now this approach is I think it is mostly done through this approach, removal of tumors in the fourth ventricle, except when the tumors are in the vermis. But we will go through these surgical indications in the last part of this presentation. Okay, so now you have the general idea of the tilovelar approach. Let me just show you a few slides of the complexity of this area. So anatomically, looking at it, we can see the CP angle or the cerebellopontine angle here. So this is this area right here. And it contains all the cranial nerves that are arising from the posterior cranial fossa. So it's a really, really complex area. This slide just wants to show you the complexity of this. We will be dealing with these structures in next of our presentations. So I hope that through time and through our hangouts, you will be able to understand this better. I know this looks quite chaotic, but what is the remarkable thing that Professor Rhoton done, he divided this area in just 3 neurovascular complexes: the upper one, the middle one, and the inferior one. So he designed an anatomical view of this area of the CP angle, which describes all the structures here with their topographical relationships to various structures, and most especially to the parts of the cerebellum. And this is very interesting because it kind of puts all this area and all this complexity into perspective. So you just have to remember the 3 neurovascular complexes and that's it. But more on this we will do in the next presentation, where we will actually consider the CP angle. To make a brief introduction to this, you can see here the foramen of Lushka, which is the lateral and anterior opening of the fourth ventricle. So if you go through this foramen here, you will eventually end up in the space between the brainstem and the cerebellum, which is called the fourth ventricle. Okay. If you remove all the vascular structures, vessels, you will basically run down to this. And this is a great slide which shows you the various parts of the brain itself in this area. So we have here the medulla oblongata with pyramids, olives, and cranial nerves arising between the pyramids and olives and behind the olives. Also, you have the pons and the cerebral peduncles here. Okay, and another thing that I would really like you to remember from these presentations are the surfaces of the cerebellum. And this is one of the most complicated ones. So this is, it's not the most complicated, but it's one of the more complicated. So this is the petrosal surface of the cerebellum, which looks to the temporal bone. Okay, so the anterior surface of the cerebellum is the petrosal surface, okay, which can be seen right here. All right. Then we have the superior portion or superior face of the cerebellum, which is looking right into the tentorium. So it is covered by tentorium, and it is called, therefore, the tentorial surface of the cerebellum. And finally, we have the most dear one, which is called the suboccipital surface. And this is the surface we have been dealing with today. Okay, so we have three surfaces basically. So the petrosal surface, tentorial surface, and the suboccipital surface. If I ask you what structures can you find on each of these surfaces, you will really, I think you can understand it right now. Because in the suboccipital surface you have the cerebellar hemispheres, the vermis, and the tonsils of the cerebellum. Okay. In the petrosal surface you have the CP angle and the hemispheres of the cerebellum. And finally, in the tentorial surface, you have the vermis and the hemispheres of the cerebellum. So it's really quite easy. You have only let's say three parts of the cerebellum which are all the time, you know, rotating around in these surfaces. So let's now go to the actual telovelar approach. So as I mentioned already, the telovelar approach is an approach to the fourth ventricle, an area behind the cerebellum here, or I mean anterior to the cerebellum, between the brainstem and the cerebellum. So as I said, in the past, neurosurgeons used to cut through this vermis, split it, and then gain the access to the area anterior to this. But then when more refined microsurgical technique occurred, they developed an approach which is going through the membranes, which are relatively safe, and it's not really the brain tissue here. So if you retract these parts of the tonsils here, next to the uvula of the vermis, you can provide a good exposure of this membrane. So this is the velum medullary, and this is the tila choroidea. This is the foramen magendae, which is the lowermost foramen of the fourth ventricle. And then, if we go more close into it, you can place your incision right here and basically open it up. And what you will see is actually you will expose the complete space of the fourth ventricle, and be able to view the aqueduct, the aqueduct which is up here. So it is the uppermost margin of the fourth ventricle. So it's really interesting. And if you need more exposure, you can always do it bilaterally, and then have all this area exposed. So this approach is mostly used for excision of the brain tumors, but it has some much more uses to it. So when will you use this approach basically? You will use it when you want to enter the fourth ventricle without the risk to injure important neuroanatomical structures. And of these structures, the most important ones are the cerebellar tissue. Then you can also use it for biopsy and pathology removal in this area. You can use it to operate on the tumors of the rhomboid fossa. Regarding the tumors, I already said that today this approach is mostly used for tumors localized in the fourth ventricle. But if the tumor is in the vermis, you can as well use the transvermal approach, which is splitting the vermis. So it's really an approach that is, how can I say, that is reserved for tumors that are inside the fourth ventricle and that are not that didn't spread to the cerebellar tissue, because then you need to remove this tissue which has been taken by the tumor. Then you have approaches to the, if you can, of course, if those are metastases or the tumor is diffusely localized in the cerebellum, then it's probably poor prognosis. Then you have the approach to the Sylvian duct, as I mentioned, which can be useful in operating on the non-communicating hydrocephalus cases, where you have the obstruction of the CSF or the cerebrospinal fluid flow. When not to use, I found only two cases which can really be argued when this approach is not favorable to be used. So this is the spinal instability. Because of the relative proximity to the atlanto-occipital junction, this approach may not be recommended in patients who have this instability of these junctions. So this mostly is in the case of children, because children need some time to develop the muscular stability of the neck and head area, so of this craniocervical junction. And also, as I mentioned, when you have the diffuse pathology of the fourth ventricle, then it is no use to use this approach. The other thing I wanted to mention, how will you remember the anatomical structures here? So if you consider the tailwheeler approach, it is mostly done in the most caudal part of the vermis and cerebellum. So here you have only two structures, and these are the tonsils and the vermis, okay? And if you consider this the same as in the oral cavity, you have the uvula and two tonsils. Okay, so Professor Rhoton would describe this as when you say ah and you see the vermis and two tonsils, you know that you're in the right area. Okay, so this is just a joke. And if you want to find out more of this and on Professor Rhoton's charm, I recommend that you view his presentations on the ANS channel. And now this part is intended as a brief discussion afterwards. So we have here Dennis, I hope still, and Dr. Bennett, and I would like to ask you, would you use the Thiele-Wheeler approach that I described in the pathology like this? So we have here a mass in this area, and let's say that it needs to be, that you need to obtain a biopsy of this tissue here. So would you use the Thiele-Wheeler approach, or would you go for this approach, which is the interhemispheric approach here? Which one is the most favorable? Which one is the best to you? What do you think?
Why don't you go, Dennis?
If you have any ideas, guys.
Yeah, I wouldn't like to say something, you know, like concrete, but it mostly looks like the diffuse pathologies, like you previously described. And we have actually from the approach, I believe, yeah, the interhemispheric, the distance is bigger, but the space you have is also bigger through the enlarged ventricles.
Yeah. So
On
it's
the other
basically
side, one could say it's a case of a non-communicating hydrocephalus because
exactly,
there's
yeah.
an obvious compression.
Yeah,
I don't know.
Dennis, that's a great point you mentioned, because I didn't want to mention this, but you figured it out. This is a case of uncommunicated hydrocephalus, which is secondary to the growth that you have here in the fourth ventricle, which is really obstructing the flow of the CSF. And that's why these ventricles look so bigger. But let me tell you, this is, I think, the most important lecture in neurosurgery, which I learned, I think, from Professor Abdulrauf on his lectures, when he said he would put the approach he did and ask us, do we think that this approach is the best option for the patient? And the discussion would go on, and then he would say that there is really not the best approach. So you need to have to make the decision which approach we do make, but there are many options in which you can operate on the patient. So it's really how can I say, the thing that is so you can't have the ideal approach in any case. So this is why I put both of these approaches here, because you can possibly do both of them. If you are a well-experienced neurosurgeon, you can do both of them without any harm to the patient, because you have really a broad area here. You just, if you do this approach, you will probably do the parasagittal craniotomy here. I mean, on the right part of the hemisphere, do the hanging hemisphere approach. Yeah, sorry.
Yeah,
Sorry.
precoronally interhemispheric.
Yeah, interhemispheric. I think it can be done this way. I mean, you can go through the corpus callosum in the anterior third, cut through it, and then go into the third ventricle, and then basically do a perforation in the floor of the third ventricle and go all the way here, or even go through the aqueduct if this is really possible. So it's the most important thing is to remove the growth here, or you can do it the easier way, or anatomically more closer way, and go through the telovelar approach. I think the telovelar approach might be obtainable. It certainly is for a biopsy of this tumor. But during the operation, you will probably need to determine how many of the cerebellum has been invaded by the tumor, and is this an invasive tumor?
You know, Slaven, I know you're a student, you guys are students, and I'm not even a neurosurgeon, but I wonder if something can be removed endoscopically, something like this, or is it too big? What do you think? I know you haven't done any surgery. Is it done in these kind of things?
Yeah, I think it can be done. It can be done. There was an interesting discussion in Dubrovnik. That's the famous republic in Croatia, the oldest republic in the world. I mean, the longest republic, long living. And there was a neurosurgeon from Japan who argued that you can remove lesions like this through an endoscopic approach. I think it can be done, because you just cut through the corpus callosum, and you can, approaches to the third ventricle are mostly done endoscopically. Okay. So you can always go with an endoscope into the third ventricle, and then you can perforate the floor of the third ventricle with an endoscope. I will have this in my later presentations, and basically go here, or go through the cerebellar aqueduct and also end up here. So I think endoscopic approach is a really smart way to operate on this. Of course, there are some old guard, let's say, neurosurgeons who would disagree with this completely, because they are always using, the, how can I say, the well-known paths.
Conventional approach, right?
Yeah, but I think that endoscope is really a smart way to do this, in my opinion, in my humble opinion. So a great remark, Dr. Bennett. I think it's really because as you said, you are doing your residency 3 years in neurosurgical TV, so you have really a giant knowledge in this area.
Well, Dr. Suryanov may discuss that tonight in the Russian conference on endoscopic surgery. Yeah,
that's amazing. Yeah, that's amazing.
Yeah,
I'm really looking forward.
They'll talk a lot about tumors. I think removal of tumors and stuff.
You can basically ask him this question when we go there. I would really like to hear his thoughts on this. So we just need to remember that there's a growth in the fourth ventricle, and can this be operated endoscopically?
Okay. Okay,
Yeah.
very good.
Very good. So, and yeah, please,
only for
Dennis.
the previous case, just I don't have much experience, or just saying, looking by the MRI, it's the age of the patient seems to be very young. It's actually a child, as I can see. Just maybe the diameter of the endoscope was probably too big for the corpus callosum, or I don't know if there are pediatric size endoscopes, because in that case, you know, maybe the size of the endoscope would be a bit of problematic. I don't know. Just
I think.
just my
Yeah, I
question.
think we have a great discussion here, because we can see how complex is it to plan an approach to a child, because that's the most complex thing in neurosurgery, because in neurosurgery it's really the discussion before the surgical procedure that is really interesting here. And I think that, you know, because we are considering here two approaches, let's say, only two, more of them can be done, let's say, but and we are considering two methods of performing them, with microscope or with endoscope. So it's really, it puts this genius diversity of neurosurgical procedures, and I think none of us is experienced enough to offer a simple solution, but still we are discussing this, and I think we will all go after this presentation and try to find our answers to this. Maybe Dr. How did you say, Suresh, or what is his name, tonight in the presentations on the endoscopic approaches will give us some more remarks on this. Okay, and this is another case here. So here I just put you this case, and I think this is really interesting. Also, it's very hard, but I think the only approach that can be done here is basically, I think Thiele-Wheeler approach is favorable to this, or you can do it supratentorially here, perhaps. So what do you guys think? Do you agree with me, or do you think that the Thiele-Wheeler approach is really not an option here?
Well, yeah, I would, you know, I don't have much experience
Yeah,
here,
you can
but
say whatever you think. It's
just from this, maybe a infratentorial supracerebellar approach would be favorable.
The best approach.
Yeah,
So it will go.
supratentorial, infraoccipital, from under the occipital lobe.
So it would
Maybe
go like
you
this.
would have to have too much cortical retraction on the cortical on the cortical surface of the occipital lobe. You have to put it a bit up. In this case, yeah, I would just say, you know, maybe infratentorial supracerebellar approach.
Infratentorial supracerebellar.
I don't
okay.
Well favorited by
That's a good idea, certainly, because, you know, as I mentioned to my colleagues in Zagreb, there was a interesting case posted by Dr. Aaron Cohen Gadol, and in his neurosurgical atlas series, and he was doing a patient which had a tumor in this region, and part of it was supratentorially, part of it infratentorially. So he did a combined supra-infratentorial approach, and he then pushed the supratentorial part infratentorially, and then put it out infratentorially. Yeah. So it's really interesting. I mean, he combined the approaches to help himself with the tumor.
Yeah, I remember Dr. Cohen's super collection of neurosurgical approaches on his YouTube channel, and I think I can correlate that he cuts a piece from the tentorium to extend his infratentorial approach.
Yeah.
I'm not sure, but I think I can correlate to one of his presentations.
Yes, which is interesting. And finally, we have this third case here. which is well, I think, you know, this thing is probably indicated of a transdermal approach, because this looks like a medulloblastoma. Okay, so I think that this is probably the midline cerebellar tumor in which you really need to split the vermis. That's why I put it, to obtain the access, because you have a pretty big tumor here, and it's basically on the base of the rhomboid fossa. So it's really interesting, or at the floor of the fourth ventricle. So it's really interesting. I can remember the remark of one pediatric neurosurgeon in Zagreb who always said that tumors which sit on the floor of the fourth ventricle are really physiologically interesting, because when you try to detach them of the floor, be it you can be as gentle as you want to be, but it will always provoke some strange physiological responses. So it's really dangerous area to operate in, and it is an area of certain dogma, I would say. I mean, it always is part of discussion whether these tumors should be operated, how should they be operated, and etc. And in which, as you saw, everything is controversial, from the positioning to these approaches. But I just wanted to show you one of the approaches which are really, I believe, in great part the provision of Dr. Rhoton and his work in the neuroanatomical laboratory, and that is the Taylor-Wheeler approach. So, and now in the last part, I would just like to go through some of the tumors of the posterior fossa. I hope you can see this. So it's really interesting that these tumors are more common in children than adults. In children, they consist 54 to 70% of brain tumors. So mostly you can find tumors of the posterior fossa or infratentorial tumors in children. In adults, they consist only 15 to 20% of brain tumors. So in adults, most of the tumors are supratentorially positioned. So most common tumors in this part of the CNS are actually metastases, and the cerebellar astrocytoma is the most common children tumor. So one type of these astrocytomas is the pilocytic astrocytoma, in which you can really see on the MRI that the cerebellum has disappeared. You see a giant cyst where the cerebellum should be, which is on the margins has this ugly looking tissue, cerebellar tissue. So it's really a most common type of brain tumors in children. And then medulloblastoma, as we discuss here in this last slide, which is mostly midline tumor in the cerebellum, which is malignant in its nature. So then ependymoma, subependymomas, choroid plexus tumors, dermoid tumors, which are developmental tumors, hemangioblastomas, and brainstem gliomas. The good news is that these gliomas, such as the pilocytic astrocytomas, are usually low-grade astrocytomas, or lowly malignant or non-malignant tumors. And this is interesting. So, and now, when we finish this, I can really show you one more movie just to see intraoperatively how this approach looks, and that will be all from me today. Okay, so I hope you guys are still alive here, and let's see. I just left without my videos here, but I'll try to find it. Okay, so that's the Taylor-Wheeler approach.
Let's say hi to Abdal. Abdal, hi. I'm Dr. Bennett. How you doing? Can you hear me, Abdal? I guess your sound's not working. Well, whatever. We'll introduce him later.
Mm-hmm. Yeah, great. That's the video I wanted to show you.
Okay.
Okay, so this is an interesting case here. of the telovelar approach to the fourth ventricle. So let's just take a moment and see how it's done surgically. And I would like to open the discussion now so you can all participate. So we have a 56-year-old man with 2-week history of headaches and double vision on left lateral gaze. Okay, so this is the image of this patient. We can see the tumor here. So what is indicated is the biopsy of this growth here. And surgical approach, which is planned, is right here. So it's the suboccipital approach. Okay, so as I mentioned, now we are really going into the intracranial part already. Bone has been removed, incision placed, and now dura has been opened and through the 2 windows, as I mentioned, and now the sinus is being ligated. So we can see the inferior sagittal sinus here. There was also a debate in one neurosurgical room, operating room. I was present, and how should you ligate the sinus here? And the best thing, as my professor mentioned, is to really ligate it, to bind it and then cut it without use of bipolar cautery. And because sometimes you can use bipolar cautery, but this is the safest way, at least in his words. So just wanted to mention this. Now, these arachnoid attachments are dissected. Pica is visualized. Pica is one of the major arteries, which is an artery of the suboccipital surface of the cerebellum. So it feeds the suboccipital surface. Hemispheres are retracted. And finally, this is the medulla oblongata and spinal cord here. And now you can see that this big pica artery is here in the surgical field. So it's dissected away to provide more exposure of the surgical trajectory. Okay. Now, also, we need to find the membranes, which I mentioned. So it's just the surgical exploration and more dissections here on the way. Isabella here is here in the okay. Left me, okay. So now it's basically opening of those membranes. And finally, this allows more gentle retraction of the cerebellum itself because the attachments are dissected. Okay, and finally, the tumor is approached. So now the neurophysiological evaluation is on because of to show that there won't be any injury to the important cranial neuronuclei in this area. And finally, the tumor biopsy is taken. So as I mentioned, this is a very simple approach. You just dissect away all the, remove from the area all the important arteries and open the membranes and urine. And what pathology showed is that this is the lymphoma. And post-operative course is unremarkable regarding the surgical technique because the patient had all the symptoms he had before surgery. Okay, And of course, because all lymphomas are malignant, chemotherapy is administered after the operation. Okay. So guys, I'll just go off the screen share now. Let me just see this. Okay, and thank you really much for joining me today in this discussion, and I really hope it was useful. I will get into this more. I mean, into hang of this, and I hope these discussions will be more interesting in the future. What I will also do is to do some broadcasts from the Croatian Institute for Brain Research, like I did last year, because this is really the the earliest, the antique one broadcast for this year. So I also want to invite you tomorrow at the same time, and that's 3 p.m. We will have another hangout with Joel Boyer, the artist who did some some Rhoton sketches. So we will try to research Rhoton's work from the artistical point of view. So thank you very much.
Okay, Slaven, very good. Is Dennis? Well, let's say hi to Abdal. Can you hear us, Abdal? He just joined us.
Yeah.
How you doing? I think you guys. One thing I'm impressed with neurosurgeons is how well they know neuroanatomy, and how much they continue to study it. I think it just helps for you guys to be around it all the time, and it's good that you're starting. It's good that you're starting early, just to be around it and so you get to know it super well. Is this approach considered to be a difficult approach, the posterior approach? Is that considered? Do you guys know that, Dennis or Slaven?
Well, I think it's not. It's one of the. I would say that it's, let's say, basic to intermediate approach, if most, because it's really not that hard as some approaches.
Yeah, it's not considered real difficult, right?
It's not considered one of the top difficult approaches, but it's usually, in neurosurgical training, it's if you are really training at the clinic, it's most of the time you won't be able to do any approach except the craniotomy,
right,
or removal of the subdural hemorrhage or epidural before you really attain some rank. So it's really a long way. I mean, so basically every neurosurgeon which attend this has some experience in operations. So
yeah, I imagine that's one of the big advantages of endoscope, right? They don't have to take off a flap of bone. This is a very naive question, probably neurosurgically.
You can do a burr hole, just a hole which is 1 centimeter in diameter, and go into it, and that's it. That's really a very neat way of doing the approaches.
When endoscopically, usually a bone flap does not have to be taken, or do they take a bone flap to do endoscopic neurosurgery? It's probably a pretty naive question.
Well, they don't have to do. It depends on the procedure, but most of the time, let me consider the endoscopic and the nasal approaches, because through one nostril you have the speculum for the instruments, and through the other one you can put the endoscope. I'm not sure really now how it's done, but I mean, you can do it through the nostrils, and you don't have to do anything.
Yeah, they're going to talk about that tonight. The transnasal approach.
Transnasal approach, yeah. So you just go through the sphenoid sinus, which is behind the nose, and you go all the way up to the Turkish saddle and to the hypophysis there. So it's really one of the progressive approaches which is widely used today. And the main thing is that you remove parts of the septum of the nose, because then you connect it to canals of the nostrils. And then you can approach the sphenoid sinus, go through it, and just go through the bone, which is the bottom of the Turkish saddle, and go to the hypophysis to operate, let's say, a craniopharyngioma.
Very good.
It's really interesting.
Okay, Slaven, any comments, Dennis, or questions, or?
Yeah, generally posterior fossa approaches, it's familiar between experienced neurosurgeons. But as Slaven said, as a resident, you won't have so much experience with the intradural manipulation posterior fossa. First of all, because the space is little, it needs really an experience. Yes, the experienced neurosurgeons are familiar with, but it really needs very much training. Here in the center I work, our chef, our director of the department has a very big specialization on child neurosurgery. So as Slaven mentioned before, lots of the brain tumors in childhood are located in the posterior fossa. So yeah, it depends on the actually on the number of the patient a center has. So yeah, big centers or professors with specialization on child brain tumors or posterior fossa can do these approaches yeah, safely.
Mm-hmm. Okay, very good. Okay, gentlemen, we'll wrap it up, and I guess tomorrow we're going to have another one. What time?
Yeah, I think it's 3 p.m. EST or
Okay.
Eastern Standard Time
Eastern time.
in the
Okay.
US.
Okay,
Yeah.
tune in tonight from Tyomin Transnasal Endoscopic Approaches of Neurosurgery with from Tyomin, Russia at 10 o'clock.
Right.
Tune in to watch. I don't know if you guys will be up by then. It'll be 4 o'clock your time, right?
Only if I have insomnia again.
Well, if you're you can. It'll go from 4 p.m. to noon, I think. So you can certainly catch part of it. And Dennis, you're welcome. You guys are welcome to come. And you too, Abdal, if you want to come. So thank you guys. I'm just going to stop it now.
Yeah.